Hi, this is Nurse Inge. Today we're going to talk about nursing care of the laboring patient. The intrapartum period or intrapartum nursing care deals with the pregnant patient from the onset of regular contractions through expulsion of the placenta or the entire process of labor. Labor can be defined as uterine contractions that cause effacement and dilation of the cervix. False labor, oftentimes referred to as Braxton-Hicks, occurs when there are contractions with no cervical changes. Effacement is the shortening and the thinning of the cervix, and that's measured as a percentage. It starts out as 0% effaced when the cervix is long and closed, and then it becomes 100% effaced as the cervix is softened and becomes very short or flat. Dilation is enlargement of the cervical os, and that's measured in centimeters between 0 when the cervix, the os is very closed and tight, to 10 centimeters when it is fully dilated. Labor is triggered by both maternal and fetal factors. Maternal triggers for labor include the stretching of the uterus and pressure against the cervix. Uterine stretch releases prostaglandins, which then increase the amount of uterine contractions. And the pressure against the cervix from the presenting part of the fetus releases oxytocin, which also increases uterine contractions. At the end of pregnancy, estrogen increases, which increases uterine responsiveness to both the prostaglandins and the oxytocin, and progesterone decreases, which allows estrogen to stimulate the uterus. Fetal factors that increase labor include placental age. As the placenta ages, it deteriorates and decreases the amount of hormones that it produces, which increases the responsiveness of the uterus to contractions. Prostaglandin synthesis by fetal membranes and the decidua also increase uterine contractions. And the fetal adrenal glands produce cortisol, which decreases progesterones and therefore allows an increase in estrogen to stimulate the uterine responsiveness to prostaglandins and oxytocin. So altogether, we have a decrease in progesterone, an increase in estrogen, which makes the uterus more irritable, and then we have prostaglandins and oxytocin that stimulate contractions and labor. The premonitory signs of labor are the signs and symptoms that we see a few weeks before the body actually delivers, so the body's preparing for labor. And these include things like lightening, where the fetus descends into the pelvis, usually about 2 weeks before labor begins. Braxton-Hicks contractions, which can happen for months, and they become more frequent and strong, they think it's kind of like practice for labor, but there's no cervical changes. The cervix itself can start to soften, or what we refer to as cervical ripening, and may slowly start to efface or dilate, but active labor is considered to be occurring when we have regular contractions and the cervix is definitely like at 6 centimeters. So people walk around towards the end of their pregnancy dilated a couple centimeters and not actually in labor. There's oftentimes a surge in energy, which is referred to as nesting, where the pregnant person will want to get things done before the baby arrives. And then we see things like changes in the gastrointestinal tract, like weight loss, nausea, and indigestion, chronic backache and low back pain from lordosis, as well as SI joint pain, and the joints are relaxing in preparation to deliver. And then bloody show, which is loss of the cervical mucus plug. And this is often a brown or blood-tinged mucus that the person will experience. That does not necessarily mean that they're in labor, but it does mean that the cervix is starting to ripen. We talk about there being 5 P's or factors that affect labor. The first one is the powers, and these are the uterine contractions. These are the bearing down powers that give us the strength to expel the fetus. And the urge to push usually happens after the cervix is fully effaced and dilated, so has reached 100% effacement and has dilated 10 centimeters. Just like with the heart, the contraction of the uterus is referred to as systole, and the relaxation or resting phase is referred to as diastole. During systole, when the myometrium, so the muscle of the uterus, is contracted, there is no blood flow to the muscle, which means that there's no blood flow to the placenta or the fetus. So there's decreased fetal perfusion during uterine contractions. And then during that resting phase, or the diastole, that's when the uterus or the myometrium gets reperfused, and therefore the placenta, and therefore the fetus. So it's important for us to monitor and record the frequency, the duration, and the intensity of contractions. So the frequency of contractions can be measured from onset of one contraction to the onset of the next contraction. So how frequently are they occurring? The duration is from the onset of a contraction to the end of a contraction. So how long are they lasting? And the intensity is measured as mild, moderate, or strong. And when you're palpating the abdominal wall of the pregnant patient, if the strength of contraction feels about as firm as the tip of your nose, then that's mild. If it feels about as firm as your chin, then that's moderate. And if it feels as firm as your forehead, then that is strong. The passage refers to the pelvis, the cervix, the pelvic floor, the vagina, and the introitus. So the passage that the fetus actually has to kind of pass through in order to be expelled from the body. The shape of the pelvis is important to make sure that the passenger can actually fit through there. So the most common shape is called gynecoid, and usually on ultrasound they just kind of check to make sure that things look normal, but we don't routinely screen for like abnormal shaped pelvises anymore. Joints of the pelvis relax at the end of pregnancy, as I mentioned, to allow the pubic symphysis to kind of stretch and allow for some extra space for the fetal head to pass through. And then when we're talking about the fetus in relation to the passage, we talk about fetal station, and that's the presenting part in relation to the ischial spines of the pelvis. So if the head is the first part through, just as an example, if the head is at the ischial spines, then it's at 0. If it's above the ischial spine, so it hasn't like really fully engaged the pelvis yet, then it's a negative. So -1, -2, -3. And if it is positive, then it means it's making its way out. So then that would be further down the birth canal. So +1, +2, +3. So a 0 station, which again is like the ischial spines, that's the narrowest diameter. And so that's what the baby has to be able to fit through. The passenger refers to the fetus, and the relationship of the passenger and the passage itself has the greatest impact on labor and how long it takes, and how difficult it is. The fetal skull is the largest diameter of the body, and the biparietal diameter is the largest part of the fetal skull. It needs to fit through station 0, so the space between the ischial spines, in order for the baby to fit out. Molding is the ability of the fetal head to change shape, and we have both sutures and fontanelles that allow the skull bones to overlap and kind of override or change shape to allow the head to fit through the pelvis. Fetal attitude is the term that we use to talk about the posture. So flexion is the best posture or the best attitude for a fetus to have in order to be delivered vaginally. Fetal lie is the relationship of the fetal spine related to the maternal spine, and it can either be longitudinal, so up and down, or transverse. A transverse fetus would be considered a type of a breech presentation, and you can't deliver a transverse or abnormal presentation. Fetal presentation then is what's the presenting part. So cephalic is head, breech is pelvis. So you can have like a footling breech or just a frank breech, which is their bottom is down, or you can have a transverse. And then the shoulder is also considered transverse, and we talk about the fetal presentation as being the structure that's closest to the cervix. So typically we say either the head, the pelvis, or the shoulder. So they're either cephalic, breech, or shoulder presentation. And then the fetal position is the relationship of the presenting part to the woman's pelvis. And so when you talk about presentation of the fetus, it's always the woman's pelvis first, the presenting part, and then the relationship. The psyche is the woman's emotional response to pregnancy and childbirth, and it's impacted by things like culture, the expectations that the pregnant person has for the delivery, whether or not they have a strong support system, and the type of support they have during labor. Include emotional support, continuous presence, reassurance, and praise in the care of the laboring patient, and give the patient information about the labor progress, and offer tips and advice on how to cope with labor pain. Provide comfort measures and advocate for the patient's rights, needs, and wishes during labor. Position is the maternal position during labor and for pushing, and this could be upright, like walking, sitting, kneeling, or squatting. It could be lateral, or it could be lithotomy, where they're supine with the legs elevated. Spontaneous rupture of membranes occurs during labor with cervical changes, and delivery is usually then within 24 hours or less. To assess for rupture of membranes, we could do a speculum exam to look for pooling of fluid in the vagina. We could do nitrazine paper, which is normally a yellow-orange color, but it turns blue from the pH of the amniotic fluid. Or more commonly, we could do something like collect a sample and send it for an amnisure test, or ferning. And ferning is where you swab fluid onto a glass slide and allow it to dry and then look at it under a microscope. But the kind of standard test these days is called an amnisure, where we send the a swab out for testing at the lab, and they make sure that it is in fact amniotic fluid, that the membranes have ruptured. Anytime you have a person who has had a rupture of membranes, whether it's something that you did or something that happened to them spontaneously or prematurely or preterm prematurely, you want to first of all assess the fetal heart rate to see how the baby is tolerating it, and then assess and record the amount of fluid, the color of the fluid, the odor of the fluid, and report any abnormals. Make sure you document the date and the time of the rupture of membranes, again, the fluid characteristics, and the fetal heart rate. During labor, the fetus typically goes through these similar cardinal movements of labor. So the passenger lines itself up, it becomes engaged with the pelvis, it's in this flexed position, and it descends down. So engagement, descent, and flexion kind of all occur simultaneously. And then to line up with the passage or the pelvis in order for the head to fit out of the pelvis, this internal rotation needs to occur, which you can see here on this drawing. You can see the head kind of lining up, and then as the fetus is like continuing to descend here, the head will begin to extend once rotation is complete, and then the head and the neck extend fully, or extension becomes complete, and the head and the face are delivered. Then, so in an ideal presentation, the baby is face down as it's coming out. The baby will kind of rotate itself to the right. So if you notice that the shoulders are already kind of turned, and so then the head will turn itself back to kind of line up with the shoulders once it's through the pelvis. So the head will externally rotate. It'll turn itself back in the direction that needs to be. And then there's this kind of external rotation, a little bit like shifting to deliver the shoulders. So we're going to help guide that anterior shoulder down and then the posterior shoulder up. So we have this external rotation, and then we have expulsion of the baby. And so once those shoulders are out, the baby usually delivers very quickly. So labor is divided into 4 stages, and then the first stage is further divided into 3 phases. We assess and monitor the laboring mother's vital signs, her response to labor and pain, the fetal heart rate and uterine contractions through external fetal monitoring in the TOCO, cervical changes, fetal positioning, and descent and station. The maternal diet depends on the stage and the speed of the progression, and activity promotes fetal descent. So we want to get her up and walking when the pregnant person can walk, and then rest helps with energy conservation. So if things are not progressing and the pregnant person is tired, then we want to allow them to rest. Monitor intake and output, especially lack of bowel movements or urination, as that can become critical and require intervention. Help maintain and promote comfort, support the family, and provide education. Safety is always a huge concern for us, and then we want to document the admission and the progression. So during the first stage of labor, this is the onset of true labor until the person reaches 10 centimeters dilation and 100% effacement. We go through these 3 phases. For a primipara, or the first time the person is delivering, this is usually the longest stage, and it can last about 12 hours. For a multipara, it's usually about 8 hours. And obviously there's people who go a lot faster than this and people who go longer. This is usually where the spontaneous rupture of membranes occurs, as well as during this phase, or this stage, sorry. So during the latent phase, the person dilates from 0 to 3 centimeters and effaces to 40%. And uterine contractions are happening kind of infrequently, every 5 to 10 minutes, and lasting about 30 to 45 seconds. They're mild, so again, about the strength of your nose. In the active phase, the contractions start happening a little more often, about 2 to 5 minutes, lasting 45 to 60 seconds, and they become moderate, so the firmness of about your chin. And this helps the cervix dilate to about 4 to 7 centimeters and efface 40 to 80%. So at the end of active phase, we're at at least 80% effacement and 7 centimeters dilation. And then in transition phase, we reach 100% effacement and 10 centimeters dilation. And at this point, the contractions are every 1 to 2 minutes, lasting 60 to 90 seconds. They're very strong. We see this, again, as firm as your forehead, so it feels like, very rock hard. And oftentimes people vomit at the beginning of transition phase, kind of from the severe changes that are occurring. It's important to know that a primips, or a primipara, may fully efface prior to any dilation at all, so they may reach 100% effacement before they start dilating. So they might get to 100 before they get to transition. So everybody's going to be a little bit different. People don't read the book before they get seen. In the second stage of labor, dilation and effacement is complete, and this is where we deliver the baby. So this can last from 20 minutes to a few hours. Contractions become more intense, and the urge to push increases with stimulation of the pelvic floor. Delayed pushing is when we wait for fetal descent, and we allow the pregnant person to push when they feel the urge. So this kind of passive descent and delayed pushing helps to increase the effectiveness of pushing and decreases fatigue. There's different ways that you can promote effective pushing, and kind of depends on what's going on with the delivery and the pregnancy. Some people believe that it's better to do open glottis pushing to avoid Valsalva maneuvers. There has been some research that demonstrates that breath holding and panting can lead to fetal hypoxia. And so it's important to, whatever the protocol is, or the typical procedure is in the facility that you're working in, to really encourage the type of breathing and pushing that your facility promotes. The mother may need pain medication during the second stage of labor, so analgesia or anesthesia during that first or second stage is typically when we see it. Obviously, I'm going to give it with the delivery of the placenta. And then in the third stage, we see a delivery of the placenta. This could be anywhere from 5 to 30 minutes after delivery of the fetus. The average blood loss for a vaginal birth is about 500 milliliters, and for a cesarean section, it's about 1 liter. With the fourth stage of labor, we have recovery and stabilization. We want to assess the fundus, the uterine position, tone, and location, the lochia for color, amounts, and clots, and then look for signs of bonding, as well as Apgar scoring the newborn within the first minute, and then the first 5 minutes for newborn. So for the fundus, it should be midline. It should be firm. Initially, immediately after delivery, it'll be about halfway between the pelvis and the umbilicus, and then it gradually returns to the umbilicus within the first 6 hours or so. Every day it should kind of decrease by about 1 centimeter or 1 finger width. The tone should be nice and firm, and the location should be midline. The lochia starts out as rubra, so it should be red. The amount, we're looking for any heavy bleeding, large clots, like egg-sized clots. If you need to weigh clots, 1 milliliter equals 1 gram for estimated blood loss. And then for bonding, you want to promote cuddling, skin to skin, uninterrupted skin time, breastfeeding if the patient would like to breastfeed. And Apgar scoring is cover that next. Includes Apgar scoring, and then taking a temp, heart rate, respiratory rate, skin color, checking for good peripheral circulation, looking at the mental status, the muscle tone, the type of respirations every 30 minutes on the newborn. So here's the Apgar score. So we start with looking at the muscle tone. And if you have a flaccid limp baby, that would be 0. If they have some flexion of the arms and legs, that would be 1 point. And if they're nice and flexed and active, good muscle tone, that would be 2 points. Next, we look at the pulse. A pulse that was absent would be 0 points. We'd be doing CPR. A pulse that was below 100 would be 1 point. And you would also be doing compressions at that point in time. And then over 100 is 2 points, so that's good. Grimace is reflex irritability, and so this is when you are stimulating, flicking the soles of the feet, flipping the baby over, drying them off vigorously. If you do have to suction and you suction the nose, you should see like a sneeze or something here, but you're looking to see how the baby is responding to some sort of irritable or noxious stimuli. So again, a floppy baby would be a 0. Minimal response to stimulation, so they're not really getting irritated with you, would be a 1. And then prompt response, turning, crying, grunting, sneezing, anything that shows that they don't like what you're doing would be 2 points. Appearance is skin color, so we're looking to see how blue is blue. So a baby who's blue and pale all over is 0 points. Most babies will be 1 point, which means that their extremities remain kind of blue or mottled, but the body is nice and pink. And then it's rare to see a baby that's pink all over, especially at the 1 minute mark. Respirations then are either absent, 0 points, slow and irregular, which is 1 point, or they have this nice, strong, vigorous cry, which is 2 points. So the perfect baby is this nice, active baby with a great, strong, vigorous cry that's actively, like, responding to or resisting anything that you do that's painful or not like warm and snuggly. And they are pinking up with respiration. So the body's becoming nice and pink, but you may still see some mottling of the extremities. So a perfect Apgar score is a 10. A terrible Apgar score is a 0. With Apgar scoring, we say that 0 to 3 for a score is severe distress. 4 to 6 is moderate difficulty adjusting to extrauterine life, and so they just need some support. So usually they need some ventilation or a little blow by oxygen or some extra stimulation, or maybe even suctioning. And then 7 to 10 is a nice stable baby. And so again, we do that at 1 minute, and then we do it at 5 minutes. Heart rate is the most sensitive indicator of oxygenation and fetal well-being, so we always take a look at the overall heart rate and make sure that it remains above 100. And when needed, neonatal resuscitation is done, and that's a tiered approach. So we start off with ventilation, and then we add in oxygenation, and then chest compressions, and medication is rare and done later on if nothing else is working. Erythromycin eye ointment is often done right away to kind of prevent ophthalmia neonatorum, which occurs as an infection of the eyes from gonorrhea and chlamydia that causes blindness. Vitamin K is administered intramuscularly to prevent hemorrhage until the liver can make its own vitamin K and clotting factors. And the hepatitis B vaccine is now recommended at birth. And so that's something that parents might want education about, why that they should do that instead of waiting for their first visit with a pediatrician. Medications that we give during labor or to assist with labor would be uterotonics, and these are medications that stimulate uterine contractions. Drugs like Oxytocin, which is Pitocin, Methergonavine, which is Methergin, Carboprost, which is Hemabate, and Misoprostol, which is Cytotec, can all be used to increase the strength of uterine contractions. Analgesics are pain medications. Morphine, Stadol, Nuvain, and fentanyl are some drugs that are commonly used during the labor process. Nitrous oxide is also safe during labor and delivery, but typically not used earlier on in pregnancy. It's normal to see a slight histamine release with morphine. So at the IV site, the palms of the hand, the soles of the feet, even the nose might get a little bit itchy. That's not an allergy. That's just, a little bit of itchy response, and that's normal. Both morphine and fentanyl can cause respiratory and central nervous system depression, especially if they're given larger doses. And they do cross the placental circulation, cross into the placental circulation. So do keep an eye on, when the last dose was given, related to when the time the baby was delivered, because the baby may be slightly depressed initially. Anesthesia is different than analgesia. So analgesia is pain control versus anesthesia is, numbing or loss of sensation. And we can do that locally, like in the perineum for tears or episiotomies. We can do it regionally, like the pudendal nerve block in the pelvis, an epidural or a spinal anesthesia can block out like a certain part of the body from having pain. And then there's general anesthesia, which completely anesthetizes the entire person by anesthetizing the brain, and then they go to sleep. With epidural and spinal specifically, but then also there is a risk with general anesthesia, there's a decrease in peripheral vascular resistance, which dilates the container size for the body, leading to kind of a relative fluid loss and hypotension. So we always give fluid boluses first whenever we can, and monitor vital signs very closely for anesthesia because we're worried about hypotension. So fluid boluses first to try to prevent it, but then monitor carefully for it and treat if you see it. And it's also important to remember that there's a lot of non-pharmacological therapies that we can do. There's aromatherapy, there's massage, effleurage, distraction, birthing balls, hydrotherapy, music. There's some people like read or whatever, so they meditate. But just keep in mind, like that gate control theory says that we don't have to use pain medication all the time. Like sometimes with just relaxation, reassurance, and some distraction, we can manage pain effectively without other medications. And so some people are going to be up for that. Other people are definitely going to want the medications. We use oxytocin not only to augment labor, which means to help enhance spontaneous labor when uterine contractions are ineffective, but we also use it to induce labor. So induction is the deliberate stimulation of uterine contractions before the onset of spontaneous labor, and oxytocin or Pitocin is probably the most common induction agent that we use. The indications typically are somebody who is either post dates, like post-term greater than 42 weeks, or somebody who is having other problems like pregnancy-induced hypertension, fetal demise, they have a placental abruption, there's something else going on where they just can't be pregnant anymore, and we want to induce them because the baby's doing okay and they don't meet the criteria yet for a C-section birth. The contraindications for induction or augmentation are pretty much the same, and it's when you won't be able to deliver the baby vaginally. And so this is if you have a transverse or breech presentation, so an abnormal fetal presentation, placenta previa, if you have a Vasa previa, if you have a prolapsed cord, if the person has an active vaginal herpes infection, those would all be reasons why we wouldn't want to induce or augment labor. The other people who fall into this category would be somebody who has had a vertical incision for a prior C-section. So they most likely had like an emergency C-section before, and they have one of those up and down incisions on their lower abdomen, and that just increases the risk of uterine rupture if you try to augment or induce. So with the induction, we do things like the Prepidil, Cervidil, or Cytotec that can do cervical ripening. So these are kind of like hormones, or there's also mechanical devices that can open the cervix. Amniotomy, which is an artificial rupture of the membranes using an amniohook, can induce, augment, or shorten labor. And just like with any other time you rupture the membranes, you want to make sure that you're assessing the fetal heart rate and then looking at the amniotic fluid color, the clarity, the smell, and the amount. Operated vaginal deliveries can be things like vacuum-assisted or forceps-assisted deliveries. So these are operative vaginal births. These do increase the risk to mother and the fetus for things like lacerations and nerve injuries. And postpartum hemorrhage also. And then operative births themselves include things like a cesarean section. We kind of lump VBACs and TOLACs into this group. So this would be, TOLAC is a trial of labor after cesarean, and that's only for somebody who had a low transverse incision with their first cesarean that currently has a normal presentation and no other complications. For So there's no contraindications for vaginal birth. So there's no other complications of the pregnancy. So we can do a trial of labor after cesarean to see if they can have a vaginal birth after cesarean, and if not, then they're going to go for a repeat cesarean. It's important to remember that operative births are treated just like other major abdominal surgeries. They're recovered post-anesthesia care, just like other major abdominal surgeries. The post-C-section patient needs to be monitored for injuries to the bladder, to the bowel, and for return of normal bladder and bowel function. When we do have a post-term pregnancy patient, so greater than 42 weeks, there is an increased risk to the fetus. There's an increased risk of C-section birth because the fetus may be too large to deliver. There's an increased risk of postpartum hemorrhage after birth, and an increased risk of trauma to both the mother and the fetus during birth. As the baby ages, the amount of amniotic fluid decreases, which increases the pressure on the cord and increases the risk of having abnormal fetal heart rate tracings. As the placenta ages, there's decreased placental perfusion, which means that the baby may not tolerate labor well. And if the baby becomes stressed during the labor process, they may have their first meconium stool inside the amniotic sac, which could lead then to meconium aspiration and increases the risk for pneumonia and respiratory compromise and the need for neonatal resuscitation after birth. Other OB emergencies that we should be aware of and always thinking about in this kind of intrapartum period are things like shoulder dystocia, where the shoulders are wider than the AP diameter of the pelvis. And what we notice is during delivery, something that we refer to as turtle sign, where the head comes out and then it goes back in, and then the head comes out and it goes back in, and it's wearing the perineum as a turtleneck. So it kind of goes out, in, but it's never making any progress. The shoulders are not progressing. To treat this, there's different things that we can do. The most common thing we do is what's called Mcroberts Maneuver, where we bring the knees up towards the shoulders to kind of widen or spread the pubic symphysis, and then another person pushes downward firmly just above the pubic symphysis in the lower abdomen, so kind of in that where the bladder would be. But in this case, it's a shoulder. So you're going to try to dislodge the shoulder from the pelvis down into the birth canal. There's also things called the Woods corkscrew and the Zavanelli maneuver, but the Mcroberts is probably the one that you'll see most commonly. A prolapsed cord can cause bradycardia secondary to prolonged compression, and that can cause fetal hypoxia and acidosis and poor outcomes. When we see a prolapsed cord, it could be occult, meaning that you can't really see it. It could be partial, meaning that there's like part of a cord there, or it could be a total prolapsed cord where the cord is hanging out of the vagina. You want to put the pelvis higher than the chest. So either Trendelenburg or knee chest position, and then you're going to take a sterile gloved hand and you're going to relieve the occlusion or the compression of the cord by lifting the presenting part off of the cord until the patient goes to C-section. So if they're head down next to the cord, you're going to try to spread, the tissues as much as you can and kind of push the head or move the head off of the cord. If it's a breech presentation, then whatever part is presenting other than the head, you're going to try to kind of gently push or move that part off of the cord until C-section. The cord should stay warm and moist and protected, and it should continue to pulsate. Ruptured Vasa Previa is when there are exposed blood vessels over the cervix in the membranes, and if the membranes ruptures, the baby will bleed to death. And you can see that in this top picture here, where this is kind of like not a normal looking placenta, and of course I can't get let's see, get my pen to work here. But in this area here, you can see like these blood vessels are kind of stretched out, and if these blood vessels were over the cervical os and the baby's head was on top of it, so if like the baby's head was here, and trying to push down through the cervix when the membrane's ruptured, it could rupture those blood vessels, and then the baby would hemorrhage and bleed to death. So we like to know if the person has a Vasa Previa prior to delivery, and then they would not be allowed to deliver vaginally. They would go for C-section. Uterine rupture can be partial or complete tear in the muscle, and the greatest risk for uterine rupture is prior C-section with a trial of labor of cesarean. So if you have a patient who's doing a TOLAC, you need to monitor them very carefully. Just a good critical care pearl of wisdom. All OBGYN nurses must be trained in resuscitation, both ACLS, which is advanced cardiac life support, so that's adult, and then NRP, which is neonatal resuscitation, and that's for the newborns. Resuscitation equipment must be available at every single birth. It's too late to go get it when you need it, so it's always, bring everything that you could possibly need in with you and then take it out when you don't need it. You can anticipate but never 100% predict complications, so it's important just to make sure that you have everything ready and with you in case. So if we do have a patient that has to go for C-section, those are usually indicated by prior C-section or placental abnormalities, such as placenta previa or Vasa previa. Dystocia, so we have a baby who's just not going to fit no matter what, or prior uterine surgeries where we know that they're high risk for rupture. If we have somebody who's failing to progress despite augmentation, or pre-existing maternal disease, so a mom who has really significant cardiac issues, pregnancy-induced hypertension or preeclampsia that usually we attempted to induce and it wasn't working well, or the baby wasn't tolerating it, or mom wasn't tolerating it, or significant diabetes, those may go for section. Malpresentation of the fetus, so a breech fetus, a transverse fetus, an OP fetus that just can't be delivered vaginally, those will go for section. And then category 3 fetal heart rate definitely, and category 2 fetal heart rate could be, especially if we can't improve it with intrauterine resuscitation and repositioning of the mom. And then multiples oftentimes will go for C-section unless they're progressing well with a vaginal delivery. So maternal choice is controversial, but there was a period of time where maternal choice was an option for picking or choosing a C-section. It's currently frowned upon or not encouraged because we know it's so much better for the baby to be born vaginally if possible. Complications for C-sections include hemorrhage or bleeding afterwards, injury to the bowel, the bladder, the uterus, the blood vessels, whatever. Hypopnea, so hypoventilation, hypotension, deep vein thrombosis, pulmonary embolus, paralytic ileus, and infection. Nursing care includes vital signs, IV access, IV fluid bolus about 500 to 1,000 milliliters, so 1/2 to 1 liter of fluid prior to anesthesia to prevent hypotension. You want the patient to be NPO, a Foley catheter to empty the bladder. Antibiotics should be given 60 minutes prior to surgery for the best outcome. And then sequentials to help prevent DVTs. We only clip hair if it's going to be in the area of the surgical site, so if it's going to be in the way, otherwise we just leave hair as it is. And then we want to position the patient with a wedge under the right hip, so elevate the right hip to displace the fetus off the vena cava. A timeout is called to make sure that we have the correct site, the correct procedure, and the correct patient. And it's done prior to every single surgery, whether it's emergent, urgent, or non-urgent. It doesn't matter to us. Complications, as I said, hemorrhage, injuries, and post-delivery complications. One of the things that we also have to watch for, though, is a complication of spinal anesthesia. And spinal anesthesia rarely can enter the bloodstream, and the patient will complain of ringing in the ears, a metallic taste in the mouth, They'll have hypotension that leads to altered mental status, and then vascular collapse, and can even go into cardiac arrest. So it's very important for us to monitor the patient carefully if they're receiving spinal anesthesia during C-section. So that is the care of the patient during labor, including vaginal births and operative births. Thank you for watching. I hope you have a great day.